Hi everyone and welcome to this YouTube session. I'm Dr. Preeti Sharma and I'm an educator on the platform of Unacademy. Well, today we are going to discuss a couple of questions which could help you in the upcoming exams, especially the NEET PG and the FMG exams. And this is going to be a mixed bag. So we plan to discuss a good set of questions which covers some important topics. Before I proceed, I just wish to tell you about a special test series that is upcoming on the Unacademy platform, and that is going to be specially curated and all the questions will be made by the educators personally. So there is a session and there's a test which will be conducted on 2nd of February. All of you must join in for the same. It's free for everyone to attempt. It will be at 9 p.m. and it will be conducted on the Unacademy app. I have put in a total of 30 questions, and after the test is over, you'll also get a written explanation and solutions of all these 30 questions. So I hope all of you do join in for this particular test series. And yes, now let's begin with the session. So let me start with the very first question, and let's start on an easier note. So the first question is on E. coli, which can be classified by their characteristic virulence properties and mechanisms that cause the disease. To which group the virotoxin producing E. coli O157H7 serotype belongs? I think this is one of the most famous questions that come in the paper. So first and foremost, when you're talking about E. coli O157H7, this is the one which is very famous for causing hemolytic uremic syndrome. You all must have heard of it. Hemolytic uremic syndrome, number one, and it is also very famous for causing hemorrhagic cystitis. So basically, if I focus on these words, the first one was hemolytic uremic syndrome, second one is hemorrhagic cystitis. So the word hemorrhage is definitely coming in both of them. Hemolytic, hemorrhagic. So definitely the type of E. coli under which the O157H7 comes is enterohemorrhagic E. coli, which is also known as EHEC. If I quickly go on to what are the other types that are given over here and what are the other things that it can cause. So when I'm talking about enteropathogenic E. coli, the P should remind me of pediatric. So basically this is associated with infantile diarrhea. This is associated with infantile diarrhea. Next, when I talk about entero-invasive E. coli, invasion, anything that causes invasion is definitely going to be associated with bleeding. So not only will this patient have diarrhea, but there's also going to be blood in the stool. So basically, I'm talking about a case of dysentery in this case. Entero-invasive E. coli is associated with dysentery. Talking about the first one, enteroaggregative E. coli. So anything that tends to aggregate will make it more persistent. So the kind of diarrhea that this is associated with is referred to as the persistent diarrhea. So these were just some additional points. Similarly, we have another one now that we are talking about. We have another one that is known as enterotoxigenic E. coli. So enterotoxigenic E. coli causes T for T. That is, this is associated with the traveler's diarrhea. This is associated with traveler's diarrhea. So I think the words themselves become pretty good mnemonics, and the answer to this question was second, EHEC, and the strain that you have to learn is O157H7. Coming to question number 2. A little lengthier, and then let's read it together. It's a typical question of the new age, that is the kind of questions that you expect in the upcoming exams now. So first and foremost, they've put up an 82-year-old woman who's come to the emergency department for excruciating pain, which is in the right flank, and fever for the past 2 days. She states that she's having trouble urinating. Her past medical history is unremarkable, and because she has a trouble urinating, a urine analysis is performed and it gives you typical features of a UTI. That is, it is showing you the pus cells and it is also showing you gram-negative bacilli. A contrast CT of the abdomen is also done, and a large retroperitoneal mass which is seen compressing the right ureter, leading to hydronephrosis of the right kidney is seen, and that kind of explains that there is a compression on the ureter. Hydronephrosis could be the reason that she's coming to you with a case of urinary tract infection, and she's coming to you with excruciating pain as well. Now obviously, since it was a mass, the mass had to be surgically removed, excised, and the histopathology has been shown over here. So now there's a very nice catch point that they've ended up writing over here is the image shown below and is determined to be malignant. So one thing they've directly told me that I'm dealing with a malignant tumor. So firstly, liposarcoma could be definitely one option because sarcoma is malignant. Leiomyosarcoma could be the second option because that is malignant. But lipoma, oma word tells me it's benign. So this is not the answer. Teratoma also can be both benign and malignant, but teratoma would have given me things like hairs, hair, skin, teeth, bone, all those kind of appearances would have been mentioned. So that's not the answer. I'm confused between a sarcoma and a sarcoma because they've told me it's malignant. Now, when I go for the location, I have been given a retroperitoneal mass, and the most common retroperitoneal cancer that I can highlight out here, which has also been a previous year question, is liposarcoma. Further, I've also been given a case study with an image out here. So what am I seeing out here? Firstly, see, whenever I'm dealing with fat, we need to understand that fat can be benign fat also, means I could be dealing with a lipoma, or it could be malignant fat also, that I'm dealing with a liposarcoma. So whenever I'll show you two pictures, whenever I'm dealing with fat which is benign, this is how benign fat will look like. What do I see? Totally white. Fat is always dissolved out, it looks white. And then you'll clearly see that if this is, for example, one fatty cell, one adipocyte, you'll see that the nucleus is somewhere pushed to the periphery. Let's see another one. If this is another adipocyte, I see the nucleus is somewhere pushed to the periphery. This is exactly what I talk about a benign fat. Means I'm talking about a lipoma, nucleus at periphery, versus look at these two. Look at what has happened to these two. Over here, the cell that I see over here, if you can all appreciate it well, I'll just highlight it. Yes, this cell out here. This cell out here, I hope everyone can see the nucleus is in the center. It's in the center, and it's not a completely clear, a completely uniform nucleus. It looks as if someone is punching into the nucleus. The margins of the nucleus are definitely scalloped. So what do I see over here? I see the presence of scalloped nuclear margins. I see the presence of scalloped nuclear margins, and this is what I call as a lipoblast. Lipoblast is something that I see in malignant tumors, liposarcoma. The nucleus will be punched out by these fatty vacuoles, scalloped margins, and that is exactly what I saw over here. Over here, the cell that I saw was a lipoblast, and therefore that fits in very well again with the diagnosis that I'm doing, that is a liposarcoma. Okay, I hope that is clear. Now, all of you also had one more sarcoma over here, that was a leiomyosarcoma. That is not the image seen. But how does a leiomyosarcoma look like? So, leiomyo, again, when I use the word leiomyo, I am definitely dealing with myo means muscle, and leo means that I'm dealing with smooth muscle. Again, there are two possibilities that I have. Either I could be dealing with a benign tumor, or I could be dealing with a malignant tumor of the smooth muscle. When I'm dealing with a benign tumor of the smooth muscle, I'll call it a leiomyoma. Just the oma word I'll add. And when I'm dealing with malignant, I'll call it leiomyosarcoma. Now, how do I differentiate? Smooth muscle will look the same in both of them, right? How does a smooth muscle look like? Smooth muscle is a cell which looks like this. And the nucleus, please watch out for the nucleus. The nucleus is a cigar-shaped nucleus. The nucleus looks like a cigar. How does a cigar look like? Cigar is something that has blunt ends. Totally blunt ends on the corners, right? So if I look at these cells, they definitely have nuclei which have blunt ends, which means these are all the cigar-shaped nuclei. So as soon as I see cigar-shaped nuclei, I know I'm dealing with some etiology of the smooth muscle. So now my next concern becomes whether it is a benign smooth muscle tumor or a malignant smooth muscle tumor. And the most important thing that helps me differentiate is the mitotic activity. So examiner will give you high mitotic count, and that is the main criteria which differentiates a leiomyoma from a leiomyosarcoma. There are many other criteria, but the most important criteria, which has also been a previous year NEET PG question, the most important criteria for differentiating a leiomyoma from a leiomyosarcoma is the mitotic count, which will be very high in LMS. So I hope all in all this question is sorted. The answer over here was definitely a liposarcoma. So let's move on to the next question. Third question says, let's read together. Large intracytoplasmic glycogen vacuoles are seen in which of the following bone tumors? So all bone tumors are mentioned over here, and we need to analyze that which of the following can show me large glycogen vacuoles. So the answer to this question is Ewing's sarcoma. First and foremost, whenever I say Ewing sarcoma, what all questions can come to my mind? The age group. Usually I'm given either an 11 to 14-year-old kind of a child. Next, they ask me what is the location, because bone tumor locations are very, very important. So usually it's the diaphysis that is involved. Next, they will ask me that this 11 to 14-year-old, usually male child, what kind of symptoms does he come with? So he'll come to you with fever. For example, if it's the knee joint affected, then he'll come to you with joint pain. And this might look inflammatory because when you do his complete blood count, you might see that there's an increase in the WBC count. You might see that there's an increase in ESR. So initially it might look like a very inflammatory or an infective kind of an etiology. But because he's complaining of joint pain, you'll obviously go in for radiology. When you do a radiology, what do you find? You see a very characteristic finding, that is onion skinning. I think everyone can very well appreciate onion skinning always means one layer, second layer, third layer. That's how an onion peel is, right? So over here you see periosteal reaction. And when you see periosteal reaction, it looks exactly like this. One layer, second layer, third layer. So radiologically you will start seeing onion skinning. Then you say, fine, there is a tumor. The tumor is in the diaphysis. On radiology, I'm seeing onion skinning. Let me remove the tumor and let me look at it under the microscope. Under the microscope, you see Homer-Wright pseudo-rosettes. How does Homer-Wright pseudo-rosette look? Rosette. Rosette always means rose-like. So the tumor cells will be arranged in a round manner like this. Like the rose petals, the tumor cells are going to be arranged. After that, in the center, you have some pinkish material. That is said to be a Homer-Wright pseudo-rosette. See the same thing over here. In the periphery, you have all the tumor cells going round and round. And in the center, you have all the pinkish material. So that's a Homer-Wright pseudo-rosette. Is it specific for this tumor? Not at all. I hope all of you remember the basic mnemonic that we have. Whenever I'm talking about a Homer-Wright pseudo-rosette, there are three tumors which can show this to begin with. There are many, but there are three tumors that can show me this Homer-Wright pseudo-rosette, and that is going to be the men tumors. MEN. I think with E, I have already told you that it is the Ewing sarcoma that is going to show me this rosette, whereas for the two blastomas means medulloblastoma, brain tumor, neuroblastoma, childhood tumors. So remember, medulloblastoma, Ewing sarcoma, neuroblastoma. These men tumors can show me Homer-Wright pseudo-rosette. And we've always had a very famous mnemonic for it. I think all of you remember from the platform. We used to learn it in two ways, that men are always right, or if you want to learn men are always fake. So the ideology that suits you can be your mnemonic. Men are right, men are fake, but remember Homer-Wright pseudo-rosettes are seen in the men tumors. Done with this as well. Certainly I think it is Ewing sarcoma. What special stain comes positive? So in all these tumor cells, suddenly I see all of them have become very pinkish. Why? Because I've put a stain called PAS. PAS denotes what? So please remember, all these tumor cells contain glycogen. And glycogen, because they contain glycogen, I can definitely say that these tumor cells are going to be PAS positive. So that was the question that was given to you. PAS positive is glycogen. Now I have a little bit of a homework also for all of you today. And that homework is going to be in the comment section below. You are going to type out after this session is over. Please type out and let me know that glycogen, the kind of PAS positivity that comes with glycogen, is it diastase sensitive or is it diastase resistant? When I'm dealing with glycogen showing me PAS positivity, which kind of PAS positivity do I have? Diastase sensitive or resistant? Well, having said that, I think all the other ones I'm kind of okay with. If I look at the other options given, chondrosarcoma will be a cartilage tumor. It won't show me glycogen. Leiomyosarcoma, I've already shown you what kind of nuclei will it have. It will have cigar-shaped nucleus. Chondroblastoma is also a very important question. This came in the JIPMER exam in 2021. And chondroblastoma is very famous for showing me this. That is the chicken wire calcification. So chondroblastoma is very famous. What do I mean by chicken wire? Chicken wire means just like a fence. You make a fence in the farms so that the chicken don't run away. So that kind of a fence. So if this is a cell, there's a fence of calcium around it. Then if this is a cell, there's a fence of calcium around it. Around every cell, calcium is going to go. So if I denote this as calcium, calcium is going to go around every cell. That's why you call it chicken wire calcification, and that is what you see in a case of chondroblastoma. So all in all, the answer over here for glycogen was E-wings, and since we're talking about it, why not do the translocation also? See, when I'm dealing with E-wings sarcoma, E will remind me of 11. E will remind me of 11 and S can be flipped into a 2. So 1122 translocation is what I see. And what is the fusion? The fusion of EWS gene, EWS, E-wings sarcoma, and fly1 gene. So we always remember that wings help you fly. Wings help you fly. So EWS gene with fly1 gene is the fusion protein that I see when there is translocation between 11 and 22. Third question also done. Let's move on to the fourth question. So first and foremost, this is a technique which is of lately become one of the most hyped up and an examiner's favorite because something or the other they're always putting up. So I hope all of you have recognized first that the technique that they've mentioned over here is a flow cytometry. And flow cytometry can show you many different type of graphs. This is, see, I'll draw out two graphs that they give. This is one type of graph where the cells will all be marked in the form of these dots. This is one type of a graph. So this type of analysis is known as dot plot analysis. This kind of analysis where all the cells are given in the form of these single dots, this is said to be dot plot analysis. On the other hand, sometimes they'll also give you graphs like this for flow cytometry. These are known as histograms. These are known as histograms. So can both kind of tracings come for flow cytometry? Yes, in fact, this was the question that came last year in 2021. So I think we should be knowing about it. So now let's come back to the question that I have over here. As I can see over here very categorically, I see that there is a FOXP3 written on one axis and CD25 written on one axis. Whenever I see these two molecules, there is only one cell that comes to my mind, and that is a T regulatory cell. But then, which is the answer over here, but they've also highlighted one column. They've highlighted one box. They are telling me or asking me what are the cells in this box. So if I trace this, which quadrant is this? You will say, ma'am, the cells in this quadrant, this is the double positive quadrant. Means on the x-axis also they have a very good interpretation. On the y-axis also they have a very good interpretation. Means these cells are CD25 positive and these cells are FOXP3 positive as well. And such cells are known as T regulatory cells. So first you will say, ma'am, we always study two cells. Either we study T cells or we study the B cells. Both of them are immune cells. They increase my immunity, right? But then comes a variety and an exception. See, B and T both increase our immunity. But when I'm talking about a special cell called T regulatory cell, this decreases my immunity. That is why it's so different and it's so famous. This has what kind of an action? This has an immunosuppressive action. This has an immunosuppressive kind of an action. T regulatory cells, immunosuppressive. So what are they? They are ultimately a type of T cells. So they are ultimately a type of CD4 only. They will always be CD4 positive. But what extra do they have? They have CD25 also and they have FOXP3 gene also. I hope all of you know that CD25 is also known as interleukin 2 receptor. CD25 is also interleukin 2 receptor. So this is a cell, if I draw a T regulatory cell, If this is a T regulatory cell, what all will it express? It is definitely a CD4 variety, but additionally it also has CD25, and the gene which is responsible is the FOXP3, and that is why the cells were showing both, and that is why I call them T regulatory cells. What kind of an action do they have? They have an immunosuppressive kind of an action. If I ask you the diseases associated with it, means that if someone has FOXP3 gene defect, what is the syndrome that the patient has? The patient lands up with IPEX. I hope everyone is aware of what is IPEX. For those who don't know what is IPEX, we can definitely put it out for them. IPEX is actually a kind of, you can say it's a kind of an acronym where every alphabet carries a different word. So what is IPEX? I stands for immune dysregulation, because ultimately the immune cells are going to get affected. So there's an immune dysregulation. Next, the P stands for polyendocrinopathy. The P stands for polyendocrinopathy. Next, the E stands for enteropathy. E stands for enteropathy. And lastly, the X stands for X-linked. It is an X-linked disorder. So repeating, immune dysregulation, polyendocrinopathy, enteropathy, and X-linked makes it IPEX syndrome. And X and X, you will always remember, FOXP3 gene results in IPEX syndrome is what you need to know. Other than that, if CD25, which is our interleukin 2 receptor, if that is mutated, it has also been affiliated with inflammatory bowel diseases. In fact, also with multiple sclerosis, they are seeing these mutations. So that was all in all about the T regulatory cells that can help you in the exam, and I hope you are okay with it. Okay, let's move on to the next question, and that happens to be this. There's a 16-year-old girl having a cat as a pet, and hands down, I think the answer is in front of you. Presented with a painless enlarged lymph node in her right axilla. Peripheral smear counts are within normal limits. The lymph node was biopsied and the lymph node showed you granulomas. These granulomas are filled with neutrophils and necrotic debris. Which organism could be responsible? I think as soon as I read the word cat and I read the word granuloma, I know I'm talking about something known as cat scratch disease. So cat scratch disease, firstly, two questions. First, they've asked me the name of the organism. I think I know. Cat scratch disease is caused by Bartonella henselae, undoubtedly. But cat scratch disease, what kind of a granuloma does it have? The kind of granuloma is said to be a star-shaped granuloma. It's a stellate granuloma. And I think it was quite a straightforward question. We'll have a look at an image of the stellate granuloma. So you can see the shape of it. It's not a round or a well-defined. It's got major projections. That's why they call it a star shape or a stellate granuloma. And is it specific for cat scratch disease? Well, the answer is no. Stellate granuloma is definitely seen in cat scratch disease, but it is also seen in another disorder, that is lymphogranuloma venereum. Lymphogranuloma venereum, the chlamydia one, lymphogranuloma venereum, that can also cause a similar stellate granuloma. But cat scratch disease, which was the concern over here, definitely causes it. And cat scratch disease is caused by Bartonella henselae. So what else can Bartonella henselae cause? What all things can it cause? So please remember, going on a little bit of microbiology, Bartonella henselae causes cat scratch disease. History of cat will be there, and in the disease, fever and lymphadenopathy. If you saw, your patient also had a classical history of a lymphadenopathy. There was an enlarged lymph node that was there. Okay, so next it causes bacillary angiomatosis, means bacillary because it's to do with bacteria. Angiomatosis means blood vessels. Lots of blood vessel proliferation will happen. Blood vessel proliferation will be noted. Okay, coming to the third thing, that is bacillary peliosis. What is bacillary peliosis? When I use this word, this is used again in regard to certain organs like the liver and the spleen. What's common between liver and spleen? Both of them have some blood vessel channels. I think everyone knows both of them have something known as sinusoids. When I'm dealing with sinusoids, they are ultimately blood containing channels. So these sinusoids end up becoming extremely dilated. When these sinusoids become dilated, whether in the liver or in the spleen, we call it pileosis. So it can be liver pileosis or it can be splenic pileosis, and that is also caused by Bartonella Hensley. So I realized that number one, it is caused by cat scratch, but number two, it has a lot of blood vessel predilection. It causes blood vessel proliferation in the skin, it can cause blood vessel dilation in the liver and the spleen. And how do I identify this? There's a very famous stain called the Warden Starry Silver stain, and I think I don't even need to ask you guys, it's obvious that you know the answer. When I'm talking about Warden Starry Silver, number one, it's definitely important for Bartonella Hensley, but where is it even more important? In gastric biopsies. In gastric biopsies, when I want to catch Helicobacter pylori, I think everyone knows that Warden Starry Silver stain is a very, very important stain that we have. Well, having said that, done with this question as well, and we can move on to the next question, which is a test that is being performed over here. So there are two test tubes that are mentioned over here, and you need to let me know what is it. So I hope you guys know this is the Hayes sulfur test. And what is the utility of it? So this is basically a urine examination that is being performed, and whenever I want to test for bile salts, I do the Hayes sulfur test, and it's one of the easiest tests that you have in a laboratory. All that you need is a test tube which has urine in it, and you need, as they said, sulfur. You need a pinch of sulfur and the test is done. So you took these are two test tubes of urine. They are filled with urine, and all that you've added on top is a pinch of sulfur. That's it. And then you're going to sit and analyze what happens to the sulfur. If the sulfur remains suspended at the top, that is actually a normal situation. If the sulfur remains suspended at the top, it is a normal situation. However, if the urine is containing certain bile salts, if bile salts are present, do you know what bile salts do? Bile salts tend to lower the surface tension. They tend to lower the surface tension, as a result of which you will see that all that bile, all the sulfur that you had sprinkled came settling down to the bottom because the surface tension was lowered. Why was the surface tension lowered? Because bile salts were present in this particular tube. So this becomes a patient, bile salts being present, and that is how you do a Hayes sulfur test, a very important one that we have. What were the other mentioned? Benedict's. I think everyone knows Benedict's test is done for glucose. Heat coagulation test is done for protein. And then the third one is anyway mentioned for specific gravity. So over here for bile salts, we are dealing with the Hayes sulfur test. Done with this question as well. Let's move on to the next one. Sustentacular cells of pheochromocytoma are positive for which of the following markers? A lot of markers written over here, and I hope you know the answer to this question is S100. Now guys, first before I jump into the description of pheochromocytoma, what all markers were written over here? These were markers of immunohistochemistry. For those who are new students and who are new to the world of pathology, immunohistochemistry, the name is suggesting, is a chemical reaction. It's a kind of a staining procedure, but you know what happens in this stain? Every time you get a similar color. The color that the stain gives is a brown color. That's what it's famous for. Depending on what marker you've used, I'll give you some examples. Whenever you're dealing with carcinomas like squamous cell carcinoma, adenocarcinoma, transitional cell carcinoma, whenever carcinomas are there, cytokeratins come out to be positive. Whenever you're dealing with sarcomas, vimentin comes out to be positive. And what about desmin? Desmin is definitely a marker which came in the last year's INI-CET exam also in 2021 November, I suppose. And this is a marker which is very important for skeletal muscles. So whenever they'll want to give you, I'll give you a hint. They gave you a case of rhabdomyosarcoma. I think everyone knows that when I'm dealing with rhabdomyo, I mean skeletal muscle. And when I'm dealing with sarcoma, I'm calling it a malignant tumor. So for sarcoma, what was the marker positive? Vimentin was positive. But for skeletal muscle, what was the marker positive? Desmin was positive. So can I say rhabdomyosarcoma is positive for desmin and vimentin? That is how the question comes. Now, what was the question that was given over here? The sustentacular cells of pheochromocytoma, they are S100 positive. So we need to study a little about pheochromocytoma. There's a very famous pattern. So what I'm going to do, I'm first going to draw it out so that there's no confusion, and then we'll proceed. So when I'm talking about pheochromocytoma, I have a pattern which is known as the Zell-Ballen pattern. It's only a very fancy name given for something which is very simple. Zell-Ballen pattern in very layman's simple terms means nesting pattern. The tumor cells are going to be present in the form of a nest like this. So I'll see these are the kind of nests that I have. These are the nesting pattern that I'm seeing. What is inside the nest? Inside the nest, I have the main cells. What are the main cells? The main cells are the chief cells because they are the main ones. I call them chief cells. Okay, so I'll label the first one. The first one, which is inside, is said to be the chief cells. And you know what kind of a tumor is pheochromocytoma? Pheochromocytoma is a neuroendocrine tumor. So all the neuroendocrine markers that you know of are going to come positive in these chief cells. Which gets you to the next question. What are the neuroendocrine markers that we have to know for the exam? Please remember, it's a lengthy list, but we'll simplify it. First, all the markers which end with in means number one, when I have synaptophysin, see it ends with in, synaptophysin. Then we have chromogranin. Chromogranin again ends with in, and bombicin. Synaptophysin, chromogranin, bombicin are markers. So three markers with in and three markers which are short forms, that is NSE, CD56 and CD57. This 6 panel is the entire panel for any neuroendocrine tumor in the body from head to toe. Any neuroendocrine tumor that you wish to highlight in the body, use synaptophysin, chromogranin, bombicin, and there are three of these, that is NSE, CD56 and CD57. So chief cells are neuroendocrine marker positive, but the story doesn't end here. Surrounding these nests, you also have some kind of supporting cells. These are the supporting cells which I'm going to draw around every cell. And these supporting cells are known as sustentacular cells. So now I'm going to tell you a story of three S's. What is the story of three S's? These are said to be the supporting cells. That's the function that they have. So they have been given another name that is said to be sustentacular cell. So another cell, another S. Sustentacular cell is what I call them. And if you ask me what is the marker for which it is positive, it is S100 positive. So I can see the three S's. These are supporting cells known as sustentacular cells, and these are S100 positive. Whatever I've taught you up till now, it's time to have a look at it under the microscope. So these first two images that I have, I think everyone can appreciate the beautiful nesting pattern that you're seeing. On a higher part, these are all the nests that you see. So definitely I can call this the nesting or the Zell-Ballen pattern. But in this magnification and in this regular pink and blue, can you differentiate the different types of cells? Were you able to differentiate what are chief cells, what are sustentacular cells? No, right? So you decided to do immunohistochemistry. I know the center cells, that is the chief cells that I'm talking about, they will all be neuroendocrine positive, and the supporting cells will all be S100 positive. So this is the brown color. If I've got a brown color technique, I'm dealing with immunohistochemistry. So this is the brown color that I've got with all the neuroendocrine markers, synaptophysin, chromogranin. Can you see the entire cells are coming brown? Whereas when I used S100, I saw the center of, see, this is one nest. The center of the nest has not come brown. The periphery of the nest is coming brown. The outline of the nest is coming brown. Why? Because over there the supporting sustentacular cells are present, and they will be S100 positive, which was exactly my question. The sustentacular cells of pheochromocytoma are positive for S100. Well, with which this question is also done, and now we move on to another very simple question, and that is this. An all-time favorite NEET PG previous year question that is regarding the cambium lead. Cambium layer is histologically seen in which of the following? Now guys, I want you also to go a little logically because all four options are equally important. Firstly, the answer to this question, cambium layer is something that I see in a case of rhabdomyosarcoma. But before I jump to that, have I already taught you leiomyosarcoma? I think you already understood that the shape of the nuclei will be cigar shape, and because it is a sarcoma, it's going to have a good amount of mitotic activity. Next, coming to fibrosarcoma. Fibrosarcoma is also a malignant tumor, but there's a very famous pattern that you need to remember for fibrosarcoma, and that is going to be the herringbone pattern. I hope all of you know what herringbone is. Herringbone is actually, herring is the name of a fish. Herring is the name of a fish. So this is the herring and this is the bone of the fish, right? That is one what I call as herring. So herring is the name of a fish. And over here I'm dealing with the herringbone, the spine of the fish, the vertebral column of the fish, and it looks like this. It looks like this. So some people learn it from the fish point of view. Some people who are very fond of stitching, you will see that herring is a type of a stitching pattern also. This is also a stitching, herring stitch it is known as. So basically derived from this fish and this stitch pattern, they say that fibrosarcoma cells show a similar pattern. So I say fibrosarcoma shows a herringbone pattern. See, you will notice that there's an imaginary line running through it and all the cells are radiating away from it. All the cells are radiating away from it. Another one, another line going like this, another line going like this, and all the cells are radiating away from it. That is what you call as the herringbone pattern, which you see in fibrosarcoma. Coming back, my question over here was cambium layer, and that is seen in rhabdomyosarcoma. By now you know a lot of things about RMS. You know it is a sarcoma malignant tumor. You know it is a rhabdomyo, means it is a skeletal muscle malignant tumor. Skeletal muscle cancer. You also know the markers by now. For sarcoma, you've understood that it's going to be vimentin positive. For rhabdomyo, you've also understood that it is going to be desmin positive. Okay, so what is this cambium layer that I'm telling you? We see that, see, I'm dealing with rhabdomyosarcoma. Sarcoma means it's a mesenchymal tumor, means the epithelium is not going to be involved. So you will see that the epithelium above is totally intact. Below that, the cancer cells are there. So all the cancer cells are accumulated in one layer, and that is referred to as the cambium layer. So the cambium layer is below the epithelium. All the tumor cells are, accumulated, or they are all, present over here. And below that, the tumor cells are very, very less. There are very less tumor cells present. So this is a cambium layer, this layer with a lot of cells. But what cells am I talking about? What kind of cells do you see in a case of rhabdomyosarcoma? We see something known as, a lot of names given to it. Some people call them strap cells. Some like to call them that they look like tennis racket cells. Some also like to call them as tadpole cells. Depending basically on your imagination, these are the kind of names given to it. And why? What is common between these names? They are not round cells. They are elongated, as if you are dealing with a strap. So you will see the nucleus on one side, and then you will see they are long. So either you can call this a tennis racket, or you can say it's like elongated like a strap, or it's going like a tadpole. So this is the nucleus, and this is the cytoplasm of the cell. And if you look very, so see, have a look at this cell, strap cell. Have a look at this cell, strap cell. This cell also strap. All of them are elongated. So when I zoomed into it, I got this cell. Do you all agree it looks exactly how I've drawn it? Means this part of it is the nucleus, this part of it is the cytoplasm. But can you see some lines in the cytoplasm like this? These are striations, because you do understand it's a skeletal muscle tumor. A skeletal muscle tumor will show you the presence of striations. But that is when I've zoomed into that extent. Examiner might not zoom into that extent, right? And you don't have the option of zooming in the exam or looking at a higher power. So examiner will ask you that if you're not seeing striations, is there any special test? Is there any special stain by which I can see the striations of a skeletal muscle? And yes, please remember there's a stain which is known as PTAH. What is PTAH? There are two uses of this stain that you have to know. Number one, it helps you in seeing the striations of the skeletal muscles. That is the primary use of it, striation of the skeletal muscle. And second one, it is also now being used for highlighting the glial fibers, brain glial fibers. However, remember the primary use is for seeing the striations of the skeletal muscle. So what is PTAH? It is phosphotungstic acid hematoxylin. It's a type of hematoxylin. Phosphotungstic acid hematoxylin is what you have in PTAH. So there's actually a very famous way of learning this, which all of us had discovered in the classes on Unacademy, because students sometimes, right now you've learned it, you'll remember it. After 10 days or 12 days, you might feel you've forgotten. So one of the students once asked me that, ma'am, there was some stain to do with pitai, and what was the pitai wala stain? So I gave him a very simple mnemonic that pitai wala stain, pitai is something you do with your muscles, right? You beat up someone when you are muscular. So pitai wala stain is the muscle wala stain, skeletal muscle stain. So PTAH is the stain for the skeletal muscles. Well, coming back, I think we've done an extensive revision, but the question was quite simple. Cambium layer is something that you see in rhabdomyosarcoma. Coming to the next question. Okay, what is the minimum number of cells well visualized or preserved squamous or squamous metaplastic cell in a liquid based preparation to be considered as an adequate cervical cytology sample? They've asked you the adequacy criteria of a pap smear when done on liquid based preparation. So the answer to this question is clearly 5,000. So this is a fact based question, not much of a concept that I can give you out here, but I definitely would want to tell you something, and that is that when we are doing or performing a pap smear, see, how the gynecologist performs a pap smear, the technique will be the same, but how I'll be preparing this slide will depend on two things. Have I gone in with the conventional technique? Conventional technique includes that famous Ayer spatula and what you use for taking the sample. Whereas have I gone for something called LBC? LBC means liquid based cytology. Have I used a container with a liquid? Have I used a broom for taking the pap smear? So liquid based cytology, which is obviously the advancement. It is always better than conventional. It's giving me better results nowadays. So the adequacy criteria of how many cells minimum I should see for conventional and minimum I should see for LBC are different. So when I'm dealing with cervix, I have two kinds of cells. I have one part of the cervix which is known as ectocervix. Ectocervix is made up of what cells? Ectocervix is made up of squamous epithelium. So one cell that I'll be seeing will be the squamous cells. The other cells that I see are said to be the endocervical cells. So that's the second population that I have to focus on. The second population is endocervical cells. See, for endocervical cells, whether I'm dealing with conventional or I'm dealing with liquid based, I should see at least 10 cells that I should see to call it adequate. Whether I'm dealing with conventional or LBC, endocervical cell criteria is the same. But over here they are asked me the criteria for squamous cells. So please remember, for squamous cells under conventional, the range is 8,000 to 12,000 cells that you see in 10 high power fields, whereas the cutoff for liquid based cytology is minimum of 5,000 cells that you see in a total of 10 high power fields. So for conventional, 8,000 to 12,000 per 10 high, 8,000 to 12,000 per 10 high power field, and for liquid based cytology minimum of 5,000. Here I asked you liquid based cytology, here your answer would have been the 5,000. Writing it once again, for conventional it is 8,000 to 12,000 cells. For liquid based cytology it is 5,000 cells, but for both of them the endocervical cells have to be a minimum of 10. With which this question is also done, and then we go on to another all-time NEET PG favorite. I think every alternate exam this question is asked and they are never sick of this question. Why is also a reason, because this tests your internship and what what all and how have you handled such a situation practically. That is the only reason of why this question is so favorite with the examiners. A blood spill in the operation theatre. Blood spill in the OT is cleaned with, or for that matter, blood spill anywhere is cleaned with what? I think everyone knows that for a blood spill, we always use 1% sodium hypochlorite. So basically, I'm using a chlorine compound. 1% sodium hypochlorite is what is the ideal answer. Long ago, many years ago, in the last BMW edition, it used to be 10%. Then the value has changed, and now it is a definitive 1% sodium hypochlorite that you need to consider. Okay, let's move on to another question that I have over here, which is in front of you. Also, the last question of this session. There's a 56-year-old man who undergoes a routine chest radiograph as a part of physical examination. So, a man who's aged 56, but the routine testing is being done. So, somewhere the symptomatology is not there. The X-ray film of the chest shows a solitary, centrally localized coin lesion with a popcorn pattern of calcification. A lung biopsy is performed and we see nodules of benign mature cartilage and respiratory epithelium, and they've given me a picture also over here. What is the most likely diagnosis? Now on the basis of the answer, the question that is given, the answer to this question is a pulmonary hamartoma. So first, before I jump into this entire ocean of things that are written, I just want to discuss with you what is a hamartoma, because half the story and the battle will be won there. What do I understand with hamartoma? So there's a very long definition which Robbins has mentioned. We'll go into that also, but let's do a basic concept of ours. Hamartoma is some tissue which has no organization. It is a haphazard tissue. Haphazardly organized tissue. Number one. Next, you'll ask me, ma'am, what kind of tissue? Is it some tissue which has come from some other organ, or is it a tissue which is of the own organ? So please remember, it is haphazardly organized tissue which is native to the organ. Which is native to the organ. So a very simple way of learning this is, firstly, hamartoma is haphazard tissue, and hamartoma is hamara tissue. Hamara tissue means it is native to the organ. So for example, like over here you were dealing with the case of pulmonary hamartoma. So what all does the lung have? You will say, ma'am, lung has bronchi, bronchioles, alveoli, cartilage. I say, okay, let's take cartilage. Cartilage is native to the organ. You agree? Cartilage is definitely a part of the lung tissue. The same cartilage just starts growing a lot in a haphazard manner. Can I also call it a pulmonary chondroma in that manner? Either I call it a pulmonary hamartoma or I call it a pulmonary chondroma, is the same thing, right? Because ultimately it's cartilage, and cartilage is apna hamara organ, hamara part of the lung. It is native to the organ, and that is exactly what was written here. So let's analyze this question, because I am dealing with the case of pulmonary hamartoma, also known as pulmonary chondroma. So the picture out here was quite a catch point. I could see a lot of blue color hyaline cartilage mentioned over here. So first and foremost, cartilage. Even if you could not identify cartilage, they have mentioned benign mature cartilage. What are the other points? This usually is an incidental finding. The patient might not always come to you with symptoms, so might come for some other finding or a routine checkup. What do you see radiologically? It's defined as a coin lesion with popcorn pattern of calcification. So another very interesting mnemonic as to how students learn it is hamartoma is everything to do with hamara, right? So they call it hamara coins, hamara paisa, and hamara popcorn. That's how they learn it. So hamara coins, hamara paisa, hamara popcorn is how they've learned pulmonary hamartoma, which is also known as pulmonary chondroma. In fact, since we are dealing with it, let's just finish it off. This is said to be the most common benign tumor of the lungs. So is this a tumor? Definitely yes. This is the most common benign tumor of the pulmonary system. Well, with that, guys, I think we've discussed quite a lot of questions and we can definitely wrap up for the day. I'll also be posting a similar session, very similar to this, as a mixed bag, which I'll be posting tomorrow as well. All these links I keep posting on the Unacademy and my own Telegram group, so you can always pick it up from there. Any further suggestions that you have, open to suggestions always, please write them down in the chat box below. Also, as I reminded you, there are certain test series coming up. Watch out for those. And apart from that, you all know that on the Unacademy app, there is a Kickstart morning ritual that we follow till your exams. We are going to have classes every day, every morning, 7:30 a.m. And these are approximately 50-minute classes. They are free for everyone to view. They just give a boost to your early morning preparation and also act as a wake up alarm clock for a lot of students. So yes, hoping to see you in those classes as well. Any other queries, concerns, guys, do reach out to me. Always there to help you. And we'll be meeting once again tomorrow. As for the PDF of these sessions, I'll be putting them up on Telegram as always. Also on the Unacademy chat community, I'll be putting it up so you can download it from either of the sources. Thanks a lot. Have a great day. Study well. See you tomorrow with another similar session. Thank you.